Thank you for joining us for Talking Sleep, a podcast of the American Academy of Sleep Medicine. I'm your host, Dr. Seema Khosla, Medical Director of the North Dakota Center for Sleep in Fargo. Today's episode is sponsored by Harmony. Over the years, we have had a few conversations about central sleep apnea, including how to treat it. Dr. Imran Iftikhar wanted to look at the data on ASV and sort through the data using a meta-analysis and a trial sequential analysis. He practices sleep medicine at the Atlanta VA Medical Center and is on faculty at Emory University. Coincidentally, the AASM had commissioned a task force to look at the evidence and created a clinical practice guideline for the treatment of central sleep apnea. Dr. Rami Khayat was vice chair of the task force. He is Division Chief of Pulmonary and Critical Care and Director of Sleep Medicine at Penn State University. Well, thank you both for joining us today and helping us to better understand the data behind ASV for central sleep apnea and for going over the new clinical practice guidelines for the treatment of central sleep apnea.
It's my pleasure to be here, Seema. Thank you for having us here.
Thank you, Seema, and pleasure to be here with you on Imran.
So Imran, let's start with you and your idea for the paper. Walk me through this.
Yes, thank you, Seema, for giving me the opportunity here to speak about the paper. But before I begin, just a little bit of background and introduction. Rami, who was the co-author on this paper, was actually in faculty at The Ohio State and one of my teaching attendings there, where I did my training in sleep. So a lot of what I've learned about ASV is from Rami himself, and so I owe a debt of gratitude to him for his guidance and mentorship for this paper. I wasn't the co-author or the member of the task force on the ASM guidelines paper that is going to be coming out soon. So I don't know much about those guidelines as such, but I will be happy to speak about the paper that the meta-analysis paper that Rami and I published. As to the question about the idea of the paper, it was mainly to understand where the cumulative evidence stands with regards to the association between ASV and cardiovascular mortality, and especially after the recently published ADVENT-HF trial, which now challenges the notion that ASV is linked to cardiovascular mortality in patients with HFrEF and central sleep apnea. So that formed the basis for this meta-analysis and trial sequential analysis.
Okay, so what is a trial sequential analysis?
So trial sequential analysis basically is an analysis that tests the credibility of the results that you obtain from a traditional standard pairwise meta-analysis. And it does so by combining an estimation of the information size, which is the cumulative sample size from the included trials, with an adjusted threshold of statistical significance for the overall cumulative meta-analysis. And it generates a graphical outcome on a two-dimensional XY axis field, which is then further divided into 4 different areas by 4 lines. So there's the area of benefit, the area of harm below, there's the inner wedge, and then there's the non-statistically significant zone. There's this Z line, which is also called as a Z curve, and if the Z line is lying in the area of benefit or harm, then that represents a statistically significant result. If the Z line is in the inner wedge, or what we call the futility area, then that means that there is strong evidence that further studies will hardly be able to change the results of the no effect results. In other words, what it means is that future studies on a topic or question or argument would be considered futile if the Z curve is in the futility area.
Oh, wow.
And so would hardly be able to change the no effect results. If the Z line is in the non-statistically significant area, that means that further studies are needed for a conclusion on whatever the analyzed topic or the question is. The cumulative Z statistic line is drawn by adding the included studies with a chronological criterion, and the last study represents the end of the line, wherever the line is ending, either in the area of benefit or harm or inner wedge, or the non-statistically significant zones. The x-axis on that represents the number of patients included. At the very far right, you have a vertically positioned line that represents the what we call the required information or RIS line to accept or reject the postulated intervention effect. That is, in a nutshell, what a trial sequential analysis figure looks like.
So it kind of helps you weigh the data that exists based on how many patients were involved in the study.
Correct, and the basis for trial sequential analysis, which is relatively a new statistical technique, is because you can get different conclusions from systematic reviews and meta-analyses. So many systematic reviews and meta-analyses have either included too few studies or there's just not sufficient data to obtain sufficient statistical power, and then that can lead to all kinds of spurious positive or negative results. Some positive findings from meta-analyses may be caused by a random error by chance rather than the true effects on the intervention. So the results from systematic reviews and meta-analyses may often increase the likelihood of overestimation or type 1 error or underestimation, type 2 error. And so, and if you're including newer studies and updating the meta-analysis, the chances of inflating type 1 and type 2 errors just goes up higher, and that's a major concern. So with the TSA, the trial sequential analysis, it reduces the chances of false conclusions because it's controlling for multiple testing, and it prevents the researchers from falsely concluding that a treatment is effective or ineffective when it is not. It also addresses sparse data when there are not many studies, so it provides a reliable way to interpret meta-analysis that may have limited or accumulating evidence. And so that's where TSA is used to estimate the effect of the intervention.
And so do you have to ask it a question? Like, do you have to sort of model it around a hypothesis?
So you do set certain boundaries, statistical significance boundaries, and specify the type 1 and type 2 error in the software. But basically, it's just you are including the data from the studies, and then the software basically puts them in a chronological order, and in the end shows you that the Z curve with the Z line.
Oh, that's really cool. Okay. Yeah. Okay. So then what was the inclusion criteria, and then what was the intervention group?
Yeah, so the inclusion criteria was Rami and I looked at primarily the randomized control trials, evaluated ASV in participants with predominantly central sleep apnea. And we looked at papers where the left ventricular ejection fraction was mentioned, and we were very strict in our inclusion criteria with regards to the ejection fraction. So we wanted studies where the participants had, or majority of the participants had, a mean +1 standard deviation of ejection fraction less than equal to 45%, and a mean follow-up duration of at least 6 months. Because there were some other studies where the follow-up duration was less than that, and we weren't interested in including those.
That's fair.
And so primarily randomized control trials in these predominantly central sleep apnea patients with LVEF less than 45%, and a follow-up duration of 6 months. That was our inclusion criteria. The intervention group was obviously the ASV group, and the control group was patients who were not on ASV but did receive other guideline-directed medical therapy for FRF.
And then what did you find?
Well, as far as the conventional pairwise meta-analysis is concerned, the pooled odds ratio for cardiovascular mortality from these 4 randomized controlled trials that formed the meta-analysis was 0.92 odds ratio. But the confidence interval was pretty wide, so it crossed the midline, and so the confidence interval was from 0.46 to 1.81, and that gave us a p-value of 0.80 or non-statistically significant. Then when we looked at the subgroups, so subgroup based on the ASV algorithm, specifically either minute ventilation-based ASV or peak flow-based ASV. So with the minute ventilation ASV, the pooled OR for cardiovascular mortality was 0.50, but still not statistically significant. The p-value was 0.61 because the confidence intervals were from 0.03 to 6.98. The pooled OR from the peak flow based ASV was 0.71, and again non-statistically significant. The p-value was 0.29. So the pooled odds ratio for less cardiovascular mortality from either minute ventilation or peak flow ASV were not statistically significant, but there was a signal that they are not as such associated with cardiovascular mortality. And so that's where we did the TSA analysis to see where the cumulative evidence lies and if further studies are needed. And so when we did the trial sequential or TSA analysis, we found that the last point of the Z-curve was within the conventional test boundaries, also called as the non-statistically significant zone. And it did not reach the required information size or the RIS line. Essentially, what it means is that the evidence that we got from the pooled OR is inconclusive at this point, and that further studies are needed to reach a firm conclusion.
So let's talk about the different. You kind of talked about the different mechanisms, the different ASV devices. So walk me through that again. So which one you talked about peak flow and you talked about minute ventilation. So let's start with a ResMed unit. Which one is that?
So the ResMed is the minute ventilation, and the Philips Respironics have used the peak flow algorithm. And I guess Rami would probably talk a little bit more about
Rami, chime in. Help me understand these.
Yeah, absolutely. Well, I don't know if I can, because I don't understand them well enough. And the one thing that our colleagues who are listening to us should also keep in mind is we don't know, because these are a little bit of it's a proprietary algorithm.
Right.
So when we say peak flow or mid ventilation, it's what they sense. So these devices have, very complicated, and they have sensing capabilities. The ResMed, company, their device analyzes the minute ventilation of the patient. Philips Respironic, the device relies as a primary sensor to make therapeutic intervention on the patient on the peak flow, which is almost a measure of the speed of the first breath, or how fast the patient is bringing the breath in. And you can technically, with some time analysis, actually calculate the minute ventilation as well. So on one level, they are similar. On the other hand, where they are different is what the companies have packed in them. So if the device sees a pattern, what does it actually do?
Right. Yeah.
Does it rely on pressure support? And how much does it add for pressure support? How much does it add for PEEP? And what's its sensing capability? Even though it's analyzing an output, but does it actually sense it as good as it should? So these things we don't really know. They are pretty much. We've had some insights on them. I may have mentioned to you, Seema, before, this study by Nitter from the Arizona group, where they did some benchmarking, where they put a bunch of these devices, old generation. Also, I have to mention too that each of these companies has, at least 2 generations of these devices, and they are different in the way they react to events.
Well, and that's it, right? Because we can't even use the ResMed unit from Serve-HF isn't the one we use now, and you can't even get the Philips one.
Yes.
So I feel like it's a theoretical choice, but not really. And are there other companies that make ASV, or is it these 2?
Right now, those are the main 2. There's I think React has a device, but I haven't seen it. When you order ASV, I think the vast majority currently in the US is ResMed. That being said, remember, Philips is available worldwide, and we're increasingly, our colleagues in Europe, we had one of our colleagues in Europe, Dr. Androff, on the ASM guideline committee, and a colleague from Australia, well-known with major contributions, Dr. Matt Naughton, was there too. So we are. I mean, when we do ASM, I mean, everyone listens to the ASM across the whole world, and you have to remember also that we have to look at these because in a few years someone else can come up with another device. So we have to know and this had affected our practice and the way we deal with central sleep apnea significantly. So it was important to put that in perspective. And I'm really grateful that Imran put so much design and thought into this. And I think the conclusion was actually interesting and very important, impactful compared. So yes, it would have been great to say, yes, we concluded the device is harmful, or we concluded the device is beneficial.
Right.
But what's important in the context of that time the study was published, which is just like a few months ago or a year ago, because people were still thinking. So the overall hypothesis was that this device is harmful in heart failure with reduced ejection fraction and central sleep apnea. And the assumption also amongst all our colleagues in the US was that any ASV device, no matter what the technology is harmful for almost any indication, so long as in this population. So this study helped move us a little bit back from the brink here, from this absolutism of it, and allowed us to look back, scientifically at things, right, a little bit. And yeah, you can, and many of us, if you remember, Seema, we were treating these patients with ASV and they were doing well before the study was published. Yeah. So it's almost we were, treating our perception more so than the patients we were dealing with based on these major changes and this, swinging into this absolute direction of like completely forbidding the device in any patient. Yeah.
Well, and those were tough conversations, right? When SERVE-HF came out, I mean, I remember being at APSS that year, and Dr. Morgenthaler, I think, was president, and it was this gigantic room at the sleep meeting where everybody was trying to figure out what to do. And I feel like that was, for me, such a formative experience. It was earlier, in my career. I'm a solo practitioner. This happened, and I'm like, oh my gosh, what do I do? Like, I don't have anyone to ask, right? Yeah. And just sort of being in that room and seeing all of these other people that had similar questions, and then to see leadership say, okay, this is what we think. This is our best guidance at this time, like shared decision-making, talk to your patients. But you're right. And then I think we kind of extrapolated that you can't use it so including treatment emergent central apnea. So is there, can we use ASV for treatment emergent central apnea in this population?
Yeah. I was just going to, as you're mentioning these trials and tribulations, I'm really actually proud of the ASM and the leadership then and now being progressive and trying to be right on the forefront of trying to help people, no matter what whether the things change. I mean, science is always changing, and what we do will always change, and we have to recognize that. But to have our organization jumping on that right away and helping us, compared, as we talked before, Seema and Imran and I talked about how, you're following the industry sometimes and you're looking at their brochures and manuals and guidelines and some of their studies. Yeah. And then they left us hanging there, both companies twice.
But I think the difference between how the ASM responded, I think that was because when SERVE-HF came out, ResMed put something out saying, stop using this, right? And that happened right before the sleep meeting. Whereas this time when the recall happened, the recall for me was like a tiny little email on the Monday after the sleep meeting. And to me, that was such a missed opportunity and not the right way to do it, right? Everyone was there. This should have come up before the sleep meeting so that collectively there could have been a conversation about what to do with the recall. So I feel like that was an industry.
Yeah, I'll definitely, appreciate them doing that at the time of the trial. That being said, I was kind of referring to the period after when we were starting, try to appraise what happened and try to understand why the trial showed what it showed, and trying to understand how the trial was done, so the post hoc analyses and all that were not helpful in it left a big question out there, and the field was moving to not touch this device
Right.
in all indications, which was a very useful tool for our patients. I mean, there
Right.
was sometimes no way to control central sleep apnea with any other device. So, and they were telling us, don't use this thing, don't use this thing. not to say that, Philips didn't do the same thing too.
Right.
So, I mean, it's disappointing. So the academy had to
Yeah.
come up with something. And I think, so we were really, I was very excited and honored to be part of this
Yeah.
new task force. So it's the same people who were at the task force before and who suggested we do this too, and a lot of our colleagues wanting to know, especially with Advent being published and all
Yeah.
that, is to see, so what are we standing on this? But I can go back to your question about treatment emergent. Is there was no issue really scientifically, or any of the industry or the academy, or no one had a warning about using it in that indication. It was always appropriate to do
Yeah.
that. But people, because of the messaging, went ahead and took away these devices. I mean, they, by their own initiative, from patients who they frankly should not have taken it
Yeah.
away from, because they didn't have the central sleep apnea with low ejection fraction. So if you had a central sleep apnea with normal ejection fraction, excuse me, or complex, meaning like mix of central obstructive or treatment emergent, with any ejection fraction, you were okay using ASV, but practitioners were very nervous and took that, start contacting patients and taking away the device. And that was not part of anyone's recommendations, actually.
So let's take a short break, and when we come back, we'll talk more about the use of adaptive servo-ventilation for the treatment of central sleep apnea. You're listening to Talking Sleep from the American Academy of Sleep Medicine. Welcome back to Talking Sleep. We're talking with Dr. Imran Iftikhar and Dr. Rami Khayat about ASV and the new clinical practice guideline for the treatment of central sleep apnea. So let's talk about the guidelines. Rami, tell me about these. I saw that they were kind of delineated for, CPAP versus no CPAP. So let's go through the guidelines.
I recommend that you have another episode on this, Seema, with some of my better informed we've had, because that's a long one.
Yeah.
And I think as it comes out, I think many of our colleagues will start looking at it and having questions and all that, and it would be very interesting. And I think some of my partners on the task force would be great to speak on it as well. Or
I think you're right, because I had a lot of questions when I read them. I was like, oh, but why? And so, I agree.
I can make a few comments, though, that may be helpful for people who are going to look at it. It is designed, or the way we approached it, it's methodologically compliant with a new system that the Academy adapted. And it's a well-known system in appraising evidence-based. So evidence-based approach or appraisal of the literature. It's called the grade system. So we had a methodologist with us, and all the ASM guidelines have been like this I think in the past year or two, where you approach the literature all with the same methodology. There isn't really much of that expert opinion and consensus. And so this is just, you let the evidence guide you. And I was validated, or no, I felt like a sense of relief to see that the way we looked at the ASV, for example, using a different approach than what Imran did, yielded similar finding, which is it's inconclusive. There is no evidence of harm. There's no evidence of benefit. So it was similar to what he did. And that was another validation, to independent approaches to appraising science and trials yielded the same conclusion. But the Academy, so it does make a little bit for a dry reading if you go for the systemic review, but the clinical guidelines, but it's required. It just tells you where the evidence came from, what studies were looked at, and why not. Well,
but you bulleted everything. Like, I really liked that. And so I feel like, if you can run through those bullets sort of broadly, this versus that, and
Yeah.
sort of with,
Yeah.
and I appreciate your point about a deeper dive will be necessary. I agree. I have so many questions.
Yeah. So one of the, it means what we avoided to do, and here I may be walking away a little bit from the guidelines themselves into my own recommendations as someone who does this a lot.
Yeah.
So please forgive me. Don't blame the ASM or the task force if you disagree. But because we avoided putting what you would call an algorithm or a chart telling people start here, and if it's this, go there. So we did not arrange the interventions. We just said there's evidence for this, there's no evidence for that, there's weak evidence here. I mean, everything was weak evidence. But in general, the overarching theme was not enough studies in central sleep apnea. No single treatment has adequate evidence for improved mortality or significant change in cardiovascular outcome. Everything that's available for the treatment of central sleep apnea, and they're listed in the guidelines, or they include CPAP, ASV, BiPAP with backup rate, transvenous phrenic nerve stimulation.
Yeah.
Some of the drugs that made the cut. All of these have very weak evidence for possibly, they received recommendation, but they received with the caveat that you really need to look at what you're trying to do here. So sit down with your patient, do shared decision making, and make sure you and your patient are doing this to target symptoms or quality of life. And that there's no illusion that you're trying to confer mortality or survival benefit on the patient, because that has not been shown. We have no treatment that improves survival or decrease cardiovascular events, or no evidence that. So these treatments may do this, but we don't have any evidence from the published literature. But we do have evidence that many treatments, especially CPAP, ASV, and phrenic nerve stimulation, do improve symptoms. And one thing that is an important link, all of these treatments that improve hypoxia may have a link into improving some outcomes, because we increasingly understand now that hypoxia burden or measures of hypoxia exposure in patients predict their cardiovascular outcome. So treatment of central sleep apnea with some of these, pressure-based devices like CPAP, ASV, or phrenic nerve stimulation decrease the hypoxia exposure in our patients, and it may improve their cardiovascular outcome that way.
Okay.
But the main reason to do these treatments is really to improve symptoms or some function. That's the main takeaway in my view from the guidelines is shared decision making and conversation with the patient and putting things in context.
Okay, but that's really helpful, because as you're saying that, it helps me contextualize the recommendations and the way that it was phrased, right? Like it said something about we recommend CPAP over no CPAP.
Yep.
And so you're saying it's not mortality, it's quality of life.
Yeah.
Okay.
And you will see in the guidelines when you kind of dive deep a little bit what the outcomes that were found in each of these, and how we weighed the outcomes too.
Yeah.
So we considered, and frankly, I hope I'm not disappointing any of the listeners or anyone by saying that we just don't have good evidence for anything we do. This is almost like critical care, maybe before the low tidal volumes came out.
Yeah.
I mean, there is no randomized controlled trial in obstructive sleep apnea showing that you decrease mortality. We treat insomnia, but we don't show that treating insomnia improves mortality in a randomized controlled trial on a high level of evidence, So it's the same thing here too. So this is not, as sleep practitioners, we are treating patients for symptoms, for quality of life, for functional outcomes. These remain the more important outcomes to target with our interventions. Mortality and cardiovascular events are lofty claims. We have not been able to demonstrate in anything we do so far.
Yeah.
But we do have evidence, or not evidence, we do have some, signal that we decrease hypoxia and some inflammatory markers and other things. And we know how important sleep is and sleep continuity and improving REM sleep and all that. So we do feel that treating patients who wake up, every minute should be helpful in some way.
That was the part I never really understood about the AHRQ thing that came out saying, well, you haven't demonstrated a mortality benefit for treating with PAP therapy. And I'm like, but why does the bar have to be that high? Like, if people feel better and they sleep better, why isn't that enough?
I had the same thought, Seema. I don't know, but I'm assuming, they start off with looking at, because we in general as a field have made that claim before, and we commissioned some trials like SERVE and ADVENT and SAVE with the assumption that CPAP or ASV was going to improve survival.
Right.
So I think it was, they may have had a little bit of a point to say, well, it didn't. But I think they got very carried away. And
a little bit.
I think so, because I think improving sleep, look at what people do to improve their sleep. Look at the whole industry around, the sleep industrial complex, if you will, the supplements, the podcasters, the all that stuff, the coaches. Sleep is important to people, and patients. We've seen it. We see it every day. We like our field because our patients feel good, and we make a difference. So it was very I was disappointed in that. And fortunately, it didn't change what we do.
Not yet.
We didn't start calling people to take their CPAP away now.
Right. Not yet. So I'm going to push you a little bit to just kind of run through the bullet points of the guidelines, if you don't mind, because I think it's important, that you guys have put in all this effort, and I hear what you're saying, that there's limited data and all of that, but you were able to generate some guidance.
Yeah. Well,
right?
So you didn't ask me to bring it to the classroom, so I do not have it in front of me. So that's one thing I would say. I did not have that assignment before. But that being said, I will do from memory a couple things that we started with CPAP. A lot of studies were done on CPAP, and we found that CPAP had improvement in quality of life, Epworth, some sleepiness, some markers, and whenever it's effective. So what we said about it is start with that, because it's something everyone is familiar with. It has not been shown to be associated or suggested to be associated with any harm. There are no caveats. Start with that. If you improve the AHI of your patient, remember we're talking about central sleep apnea. If you improve the AHI enough, the AHI burden, then, stick with it and explain to your patient that you're doing this treatment because it does generally, improvement in some functional outcome like sleepiness, cognitive function, perhaps 6-minute walk test in some studies, and it improves the hypoxia. So it may reduce the risk down the line of cardiovascular event related to intermittent hypoxia. So that's a CPAP. Now, we also said about the CPAP, when we looked at the studies, we found little, like small number of participants in each study for each diagnosis. So, for say primary central sleep apnea, there's really nothing out there. For central sleep apnea and preserved ejection fraction, central sleep apnea and reduced ejection fraction, treatment emergent central sleep apnea. The irony of that also, Seema, as we recommend CPAP for treatment emergent central sleep apnea, meaning if the treatment emergent central sleep apnea resolves spontaneously, keep the patient on CPAP, obviously, But, so we recommended it as, initial therapy. The other important new entrant in the guidelines for the first time ever is the phrenic nerve stimulation. And this makes an appearance for the first time. There was a pivotal trial in 2016, and it was FDA. So the treatment is ironically the only FDA-approved therapy for central sleep apnea right now on the market. The CPAP does not have that specific indication, or ASV, or anything we do. The only thing that's approved by FDA is or has that FDA designation is the phrenic nerve stimulation. So, we said, look, the treatment is effective. Patient selection is important, but it is obviously invasive and it's expensive. And you may have heard on the news how Medicare is starting to look at, the implantables and the neuromodulation in a little bit more scrutinizing way. So we said this obviously should not be the first line, just like we do with the hypoglossal nerve stimulation. We start patients on CPAP or even ASV, and then we say, look, you failed these mask-based therapies, you're not tolerant of them, let's look at an implantable therapy. And we would need to have obviously full disclosure that the results of, or the impact of the phrenic nerve stimulation implant would be on hypoxia, on sleepiness, on functional outcomes, not on mortality or events, So this one makes an entry into the guidelines. CPAP is there as a first line. So we go to ASV and we say ASV has probably the strongest evidence. It's always been the most effective. You put most patients with any type of central sleep apnea, from technical standpoint, the ASV will eliminate it because it'll ventilate them through the central sleep apnea. And so it's effective for treatment emergent, for central sleep apnea and heart failure, without heart failure, anything, it'll work. But then we talked about, we focused put a lot of attention on the population with reduced ejection fraction. And we said, given the findings of SERVE-HF, we really wanted to make sure that we look at this with somewhat of a hypothesis that ASV is harmful. So then we took the ADVENT data, we took a couple other small trials we found that fit the criteria, and we put them in another meta-analysis. I think Imran refers to this as, Imran, is that like a static meta-analysis?
I guess the pairwise meta-analysis.
Pairwise, yes. Yes, thank you. Sorry. But yeah, so it's that other one, the traditional, pairwise one. And we did not find mortality. Of course, we did not find survival signal. We did not find mortality signal. So we concluded that it's not ASV as a class. And I think I want to go back to that because I also interpret Imran's study as also showing that as a class of treatment, anything that does what ASV does, meaning it ventilates you through the central apnea and holds off on the ventilation during normal breathing between central events, anything like that's ASV that got tested in these meta-analyses, the trial sequential that Imran did and the pairwise one that the Academy did, they do not have a harmful class effect, but there is no benefit that can be gleaned either. So then we said, look, talk to your patient and figure out how you move forward. If the patient didn't respond to CPAP and so for example, your tech did ASV, they failed CPAP during the titration study, but they responded well to ASV, sit down with the patient and say, look, you responded well to this treatment. And I think, so I'm talking about specifically the low ejection fraction, because remember, this was not an issue for normal ejection fraction. So then you sit down with the patient and say, look, I, find that you responded well to this. I would be okay with you using it. It's going to improve your symptoms. For example, make your sleep more continuous. It'll make you more refreshed potentially. So we're going to monitor these markers. We're going to monitor your hypoxia markers, meaning, we will make sure you're always, we eliminated your hypoxia due to the sleep apnea. And then what we added, which wasn't before, is generally for central sleep apnea, and I think you mentioned that before too, Seema, it's a fluid situation, it comes and goes, and sometimes it is more obstructive, sometimes more central, patient's physiologic states change. So this is not something you plug and play or you autopilot the patient like your OSA patient on CPAP comes once a year. The patient, especially the heart failure patient who has central sleep apnea, we do need to see them way more frequently. We need to look at their, bicarb on the chemistry, occasionally get a gas to make sure they're not being overventilated, make sure we're aware, documenting their cardiac function, their functional status, whatever their cardiologist is doing. Making sure we're aware that their main issue here is heart failure. And I'm sorry, I've been talking a lot here, but one thing I do not want to stop talking before I mention is the Academy really emphasized treat the underlying disease. So important. Sometimes you don't have to do anything.
And you're right. When we were prepping for this, we kind of talked about how we sort of accept that there's night-to-night variability in the severity of obstructive sleep apnea, but the characteristic of obstruction remains pretty consistent. Whereas with central sleep apnea, it's so dynamic, right? And sometimes they'll be a little bit more central, a little bit more obstructive. And so it's this ongoing kind of dynamic process that, it can be a little bit more challenging to navigate, I think. And so you guys also talked about oxygen and acetazolamide.
Yes. And so for oxygen, we found few small observational studies. It's a sore spot because, one of my teachers and mentors, Dr. Javahiri, has been trying to do this oxygen trial almost all his career. And we came close to doing it. But then with Susan Redline and Bill Abraham and many of the experts in the area. Anyway, the NIH kind of stopped that during COVID. You may have heard about it. So we do not have adequately powered randomized controlled trial on oxygen, but there is some evidence. So we also say here, consider oxygen as a therapy. The evidence for it perhaps is a little less than CPAP and ASV, but it's a tool you can use. Usually it's a low flow. You start half liter, 1 liter, so you look at the studies, they've done different things, but you certainly want to avoid, obviously hyperoxygenating the patient. But it's something that can be helpful. And acetazolamide it's been a to-go-to for some people. When you ask our colleagues, when I'm in meetings, I'm around to people, I ask them, are you an acetazolamide person or are you not? And I'm hearing more people being acetazolamide person. Like, for example, they'll see obstructive apnea in some centrals and they'll throw that in instead of so they put them on CPAP and add that, or they put oxygen and that. So it does kind of, but the evidence is, it's very, two very, very small short-term studies. So again, and that's a diuretic. You cannot forget the patient on it. You do have to look at their metabolic profile, just like you do with ASV, with any treatment for central apnea, but specifically because this is a diuretic, so you have to monitor the patient.
And so tell me about the bilevel PAP. I was kind of surprised that it was against bilevel PAP without a rate, but it was for bilevel PAP with a rate.
Yeah, this had, so when the Academy put the guidelines online, and many people commented on that, like, where do you guys come up with this? You don't even know that BiPAP, if you're saying like BiPAP altogether, you're not even sure it's beneficial, but you know that this is harmful, and what's your evidence? And it wasn't like that, so because if you look at the level of recommendation for BiPAP, and please don't go because I'm not looking at it now, but it was very weak recommendation for BiPAP with backup rate. But because the BiPAP without backup rate, especially if it's used with a wide pressure support.
I wondered.
Yeah, it can reduce your CO2 and induce respiratory control instability. So there was a caution based on that, and it was based on some observational studies and then some experience in labs and in research labs where people, for example, when I was in fellowship, we used to use it for to destabilize the patient. So like if you really like you're trying to how we're talking about night to night variability. You take a patient with central sleep apnea and you want to do a research study and you got all the staff there and you're waiting for things to happen and nothing happens and patient is not doing central apnea. If they were on a mask, and all that, then you can throw in like 7, 8 of pressure support, drop their CO2, and they start cycling.
Yeah.
So you can induce central apnea by hyperventilating a patient. Yeah. So that was the caveat. I do get your point, and I'm like that too. Most people use pressure support like probably 3 or 4 centimeters. Yeah. So I don't know if that applies, but again, it's caution is advised that don't put a patient on BiPAP without backup rate who's known for having central sleep apnea, because they may even look okay now, but their physiologic situation changes later. So the backup rate at least allows you to ventilate them through that and maintain a baseline ventilation. The issue is here again is you do need to see these patients regularly, so you can make some decisions, some assessments. We didn't want to burden people with what to look for every time you see them, but as a clinician, you're giving them a ventilatory device. So you may decide your patient is just fine. You may look at their chemistry. Like I said, you may look at their general state of health, cardiac, pulmonary status, their sleep, their download, their periodic breathing rate, if that's increasing, decreasing, are they in AFib, whatever. So you want to try to get a more holistic assessment and more careful cardiopulmonary, functional, sleep-oriented assessment and metabolic assessment of patients with central sleep apnea.
2025 marks the 50th anniversary of the AASM. Here is Dr. Philip Westbrook reminiscing about the early days of the AASM.
What I discovered was that there was no pathway to joining a structure because this was an association of centers, not individuals. And we were obviously not a center. And the Sleep Research Society, you had to have some published research, quite a bit, to do that. I didn't have any published research in sleep. I was trying to get into do that. To my everlasting gratitude came Bill DeMent, who came up to me afterwards and said, I'd like to talk to you more about this and your struggles, and would I serve on a committee of some sort? Bill caught me at a time when I was not going, frankly, anywhere with my pulmonary physiology work. I was very ready to sort of go from pulmonary to really try to do something in sleep medicine. But as I mentioned, I think before, that there was no easy pathway for that. There was no pathway for clinical medicine practitioners such as myself, or really pulmonary physiologists such as myself, to join. I thought there should be.
Now back to our conversation. So let me ask you guys, do you guys routinely score central hypopneas?
I do score central hypopneas or pay attention to those. That helps me understand the overall physiology of the pathophysiology of the patient's breathing.
How about you, Rami?
I do. When I was, I've been moving across institutions. It just got implemented here now where I am. It's important. It allows us to understand the full spectrum of the disease, the central sleep apnea, and I think increasingly, we remember we had this kind of like a white paper recently. And we discussed how more and more people are interested in that scoring because it allows you, the nature of it is if the apneas are 20% of the events, then 80% of your events are not used to define the underlying pathology. Right. And automatically, people are just putting them in the obstructive bucket. And And then, that could explain perhaps why some people don't respond to CPAP and have treatment emergent, for instance, So we do need to do more precision approaches. And it, now if you ask me, do I have a good way to score hypopneas? No, but it's important to think about scoring them and try.
Yeah, because practically, right? Sometimes the software, you have to create that report with like a different label, and then you kind of wonder for the people who don't do well on Inspire, right? Did they have a bunch of central hypopneas or something like that? There's so many questions, but you're right. It's not as straightforward. And I'm surprised because we've been talking about this at least for even for us, like a decade. It's just, the software isn't always, doesn't make it easy. And then how do you pull it into the total? And then how do you sort of lump it into the central bucket on the report without just scoring them central apneas? There's sort of the implementation of that has been challenging.
Yeah.
But when you look at the raw data, yeah, absolutely.
Yeah, and the actual scoring too is sometimes very difficult, classification.
Yeah. So, Rami, when you mentioned kind of that bench research that was done in Arizona, do you mean Dr. Sai Parthasrathi's work?
Yes,
so tell me about that.
The first author was there. So I think they took 2 generations of ASV by one manufacturer, 2 generations by another, and I think they had like a BiPAP or bilevel or something too. And there is, when manufacturers make these devices, and also the ventilator manufacturers, Draeger and others, they have access to these. It's like I'm not gonna call them it's computers that can generate an event, and Dr. Parsari has a little bit more of a. It's like a. He's a very intelligent man. If you know him, and great scientist, wonderful. And he's had a setup with it's physical and digital. And I think this one was just mostly they used a digital computer that simulated variety of events that were central, like complex sleep apnea or some obstructive, and expose these devices to the same scenario to see how they behave. And each of these devices, so like you look at 2 generations of ASV by 2 different manufacturers, each of them behave different. So imagine now when you send your patient on ASV with what people say, quote unquote, like open settings, your wide EPAP and a range of pressure support. And then the DME company, like in the days when there were options, may call you and say, I want to switch. Can we switch him to a ResMed device or Philips device? Or we have this, we have that. So you switch them. But you don't really know what this device is doing with the patient's events. And if that patient is more of, physiologically, fluent, if you will, like they have heart failure, they get volume, they lose volume, they take medication, they're on opiates, sometimes they take more, sometimes they take less. So the device will behave very different. Each of them behaves different.
Yeah.
So this was just a benchmark testing, just confirming that the therapeutic part of each of these devices is different, even though they're all called ASV.
Yeah.
But even within the same manufacturer, the way the device behaves is different from a different generation of the same device. Yeah.
Yeah, I remember you kind of characterized it in a way that made sense for me. You kind of talked about these machines like a ventilator in the ICU, right? Like we know that high tidal volume is not great, but a lot of it depends. It's not the machine; it's like how you set it.
Yeah, it was interesting. When you think about it philosophically, that ASV was harmful in this population. Dude, it's as if we all use ASV the same way,
right?
And that's not true because we don't all use the same vent the same way. And you can't say the vent is harmful in ARDS because there was high mortality in the arm that had high tidal volume. It's just the way it was administered. You can, because you can use ASV 99% of the time as CPAP by allowing it like 1 centimeter of pressure support to give the patient. Then it's working as pretty much CPAP. Or you can set a backup rate and minimum and maximum pressure support and it becomes like a
A
BiPAP.
BiPAP, yeah.
So,
Yeah.
and even when you download the patient on ASV, sometimes you realize that the ASV feature wasn't really engaged most of the night, most of the month you downloaded, and the patient was getting CPAP. So are we saying CPAP is harmful too when we said serve-HF is harmful?
Huh.
So there's an argument here that are all pressure devices harmful since, none of them really received the same kind of trial the same setting, the same context
Yeah.
that serve-HF did. So the company and many of the people interpreted that study said, oh, that the harm is limited to the population that was tested in this particular
Yeah.
trial. So now, a skeptic may look at this and say, well, it wasn't tested in preserved EF in the same way. There was no randomized controlled
That's
trial.
true.
So how am I to conclude that it's not harmful there? And then,
That's
how
true.
about like CPAP there, and how about another text? I mean, there was no adequately powered randomized controlled trial of these settings. So could it be harmful in all these settings?
Well, and that's kind of like Dr. Jellick and Dr. Gottlieb's work on, is the pressure too high, and are we sort of creating these pro-inflammatory situations by overstretching the lungs?
Yep, I mean, that's one way, that's one possible mechanism of harm. So fortunately, at least the work that Imran did and the Academy review of ASV allows us, like I said, to walk back from that conclusion a little bit and get in a sanity box. But frankly, it was not possible to look at, the way we all reacted after serve-HF. And it was interesting. This never came up as much, from 2015, 16 to now, that no one said, but you could see that making its way into the ARC, review, into others. Like, people just became very skeptic with any positive pressure. But no one said it, that could this be harmful in everyone? But one of the possible conclusions was that. But these, meta-analyses of the trials allow us to see, well, there's really no class effect. It's not harmful, but it may not be, so.
That's fair. So I'd like to ask each of you for a takeaway message. Imran, let's start with you.
So I would say that a lot has changed since the serve-HF trial was published. For one, there are now better medical treatments for FRF, so we may see a difference in the clinical phenotypes of the CSA patients even. The minute ventilation ASV machines used in serve-HF are no longer being used, and the new ones, the new minute ventilation ASVs, do have features that their previous versions did not, and specific the auto EPAP. The P-flow ASV machines used in Advantage trial did not show statistically significant effects on cardiovascular mortality in the subgroup of the CSA patients. But as you know, the manufacturer is facing certain challenges here in complying with the FDA regulations, so they're not manufacturing or selling these in the US. So for now, it seems that we've come full circle. And as I mentioned in the paper, in reaching a clinical equipoise, you're leaving it to the clinicians to decide and, I guess, to engage with the patients in shared decision making as to the use of ASV machines. But the evidence is inconclusive at this point on the use of ASV on ASV and cardiovascular mortality.
Rami, how about you?
I want to say amen to what Imran did. Actually, it's perfect. I would say just remember, treat the underlying disease very well, characterize your patient well, and follow up regularly with the patient who you're treating for central sleep apnea. It's not the same as obstructive sleep apnea.
Imran, I have to ask you, did you take like a statistics course? Like, you know so much about this.
Thank you. No, I mean, I've been learning the different statistical techniques and meta-analyses over the years, and so.
Wow. Yeah, I've been very intentional about not letting my eyes glaze over when we talk about statistics. So it was very enlightening for me.
Thank you. I didn't, but I think many of the listeners are familiar with Dr. Iftikhar's work too in similar approaches to in meta-analyses and exercise in CPAP and hypertension are highly impactful in the field. They put kind of everything in context at one time and point and allow us to look at the size of the effect and of a certain intervention. So So we're fortunate to have them kind of focused, residing in the sleep world.
Yeah. I know. Now I know who my go-to statistician is going to be.
No, thank you. You both are very kind. Thank you. Appreciate
Well, thank you both for joining us today and helping us to better understand the data behind ASV for central sleep apnea. And even though begrudgingly, Rami, you were able to review the new clinical practice guidelines for us for the treatment of central sleep apnea. So I appreciate both of you.
It was our pleasure. Thank you so much for having me.
Thanks so much. Yeah, thanks so much, Seema.
Thanks for listening to Talking Sleep, brought to you by the American Academy of Sleep Medicine. For more podcast episodes, please visit our website at aasm.org. You can also subscribe through your favorite podcast service. And if you enjoyed this episode, please take a moment to leave a rating or review. For more feedback or suggestions, email us at podcast@aasm.org. I hope you'll join us again for more Talking Sleep. Until next time, this is Seema Khosla, encouraging you to sleep well so you can live well.